Thank you, everybody, for joining us today to our webinar brought to you by the National Center for Health and Public Housing. Today, we're going to be presenting on housing and health partnerships, putting theory into practice. This is also going to be presented by Dr. Kevin Lombardi, who is our Manager of Health Research, Policy, and Advocacy. Thank you, Kevin. Please.
Hi, everyone. Thank you for coming and thank you for the service you give to your communities. Today we'll be covering a lot, and in particular, we'll be looking at health and housing partnerships and some of the pragmatic details that I believe are particularly high yield for those working at FQHCs and housing administrations and associated organizations. A wide body of evidence has established access to safe, affordable housing as a critical element to individual and community health. Because of this, health centers around the country seek to strengthen their health housing partnerships, collaborations, and so forth to support population health. Managing multidisciplinary partnerships is complex. In this session, we'll take a practical view of the evidence by reviewing frameworks and methodologies that support health housing partnership in real-world circumstances. This session will not be comprehensive, but will review certain elements of health housing partnerships. The elements I have chosen are based on my own experience as a medical doctor and epidemiologist, a comprehensive review of the established literature, and most importantly, through interviews and consulting appointments with FQHCs around the country. The opinions expressed in this session are my own. We'll also engage with case studies that are designed based on real patient experiences and the challenges that health centers and their patients experience together. At the end of this session, I hope that all you are able to take something concrete home to support your ongoing efforts on an organizational, professional, and a personal level. You will receive the slide deck via email. The slides include links to key resources and literature that can be used to construct proposals and support your ongoing efforts. We won't be able to cover everything in the material, all the material during our session. So if you'd like to take it further, there's plenty of information in the deck for you to do so. Also, please feel free to distribute the deck widely to colleagues as you deem appropriate. The session will be participatory. We have 2 discussion questions. Our audience is exceptionally diverse, and we hope to shine light on that diversity through our discussion questions. Fide?
Thank you so much, Dr. Kevin Lombardi. So again, my name is Fide Pineda, and I will be helping facilitate today's webinar as well. So this is just a kind reminder to everybody before we begin that all participants are muted upon entry. Please make sure that if you have any questions or any comments or any promising practices that you would like to share with us related to today's topic, that you can do so by engaging in the chat. Raise your hand if you would like your line to also be unmuted. And this meeting is being recorded, and the slides and recording link will be sent to you via email after today's session. This is just some information about the National Center for Health and Public Housing. The mission of NCHPH is to strengthen the capacity of public housing primary care grantees and other health center grantees by providing a training and a range of technical assistance. NCHPH is a project supported by the Health Resources and Services Administration, and is also a national training and technical assistance partner. The information presented today are those of the author only. So here we have some data related to health centers that are close to public housing. This data is regarding residents of public housing and their enrollment as patients as federally qualified health centers. Perhaps more than any other in this demographic class, residents of public housing rely on FQHCs to obtain their health care. A total of 108 FQHCs serve as public housing primary care grantees, covering just over 900,000 patients. And additionally, there are 458 FQHCs that are in or immediately accessible to public housing that cover approximately 5.7 million patients. This is all according to 2021 UDS Health Center data. And then in terms of demographics of residents of public housing, as it is displayed in this infographic, we can see that 1.5 million residents demonstrate characteristics that are differentiating from the general US population. For example, residents of public housing are approximately 2 times more likely to be African American, 1.5 times more likely to be Latinx, and 1.5 times more likely to be children. Residents of public housing are also disproportionately from households that are low income and female-headed households. All right, and I'll pass it on to Kevin Lombardi.
So our session content objectives will be reviewing evidence supported frameworks for implementing health and housing partnerships. We will perform an overview of methodologies for practical health housing partnerships and take a practical view of the limitations and challenges in health housing partnerships. This will be performed by lecture and by the resources available on this slide deck. Next slide, please. Health cannot be comprehensively understood or supported without an understanding of the whole individual. The social determinants of health provide us a framework for conceptualizing this. These diagrams display this visually. The perspective they impart will be integrated into the remainder of the session material. Next, please. Health housing partnerships are a cornerstone of the social determinants of health. And the social determinants of health are the result of a process based on our understanding of human rights, policy choices that we make based on those understanding of human rights, and a desire to create more equitable outcomes in our communities. For those of you who would like to see a more global view of the social determinants of health, I'd recommend reading this report in depth. Thank you. Next, please. And the Healthy Together Toolkit is a cool toolkit created by our organization and NNCC and HUD that describes the various types of housing programs available at the state and federal level, as well as recommended frameworks for partnership, the detail of which we do not have time to go over in this session. But for those of you who are working on health housing partnerships and would like details regarding specific programs, specific things that can be done with specific programs, and how to facilitate the partnerships, my recommendation for a next step would be to open the toolkit and use it as a playbook. Next, please. We will start by reviewing a case study. At the end of this study, we'll answer a series of questions in a discussion section. As we review this information, I recommend that you jot down key details or type down key details as I read them. I'll begin reading them now. The case study, Mrs. Torres is a 67-year-old female with past medical history significant for type 2 diabetes, stage 1 kidney disease, and hypertension. She presents at her primary care office for her annual wellness examination and to receive refills for her prescriptions. She denies any acute health issues. At intake, vitals and SDOH screener are performed per facility protocol. Results are as follows. She has a heart rate of 82, blood pressure of 140/86, and respirations of 22. We have access to results from a previous exam 6 months ago that showed the following: heart rate of 62, blood pressure of 120/78, and respirations of 18 per minute. The intake nurse indicates that Mrs. Torres appears diaphoretic, sweaty and pale, and nervous. Next slide, please. The results of Mrs. Torres's screener displays the following results. I'll give you a moment to look at those. Next slide, please. And this is the remainder of her SDOH screener performed at intake. Next, please. In the examination room, Mrs. Torres is seen by a nurse practitioner who reviews her vitals, recent lab results, and performs a physical examination. Lab results indicate the following: sodium that is high, potassium that is within normal limits, BUN and creatinine, which are both high, and a normal FOS. Mrs. Torres's physical examination was unremarkable, save some mild shaking and nervousness. Next slide, please. When interviewed regarding her SDOH screener, this is in the exam room, Mrs. Torres mentions the following. She lives at home with her husband and adult daughter. She's the only source of income. Her hours were cut by 20% 6 months ago. Since then, her family has lived on savings, which are now gone. Her family has struggled to meet rent. She was evicted once in her early 30s. She was overwhelmed by fear that this could happen again. Mrs. Torres is examined and diagnosed with GAD and MDD during her visit. She was started on citalopram, an antidepressant, and networked to social services, who schedule a consult with her for the next week. And next will be our questions. Please take a moment to consider the following questions. Excuse me. How are Mrs. Torres's non-medical challenges impacting her chronic diseases? What types of services could be helpful in supporting Mrs. Torres? And how should these services be delivered? Please take 3 minutes to consider the case and to compose a response. I'd recommend that you either write the response or put it directly in the chat. In 3 minutes, we will take a look at the chat and we will accept hands. I'm looking very forward to hearing your unique perspectives and thoughts about the case and the questions. So Fide, if we could take a few seconds and just stay on the questions and then rotate through the case, please. Thank you. I'll begin a timer for 3 minutes. Thank you all for your participation. I'm looking very forward to your thoughts and insight. If you could go a little slower on that, please, Fide.
Yeah.
Thank you.
Yeah. I was just scrolling to start it from the beginning. There you go.
And I will say that for those of you who are involved in administration or social services, we greatly appreciate your perspective as well. I will put the questions in the chat right now. Thank you. Another 20 seconds and we'll take hands and then we'll go to the chat. Okay, Fide, if we have any hands, could you ask those? If not, could you call the individuals who were nice enough to put something in the chat for us, please?
Okay. So we do not have any hands raised, but I would like to call on Carol Lemus.
Hi, Carol.
I'm not a doctor, but have lots of my own health problems. So the sodium is high, as well as the BUN and CRT, which I believe all have to do with the kidney function. And they're high. Blood pressure is also high, but she is nervous. She could definitely use assistance with applying for benefits, particularly financial benefits.
Mhm.
And services should be delivered in her home, particularly since she has limited income and travel doesn't fit into her budget.
I really like something you said there, Carol. May I call you Carol?
Yes.
So you make some very good points there. This is an individual who has very serious chronic disease, and chronic disease that in the past seems to have been well managed, but now seems to be getting worse. And the case kind of points to something that we see often in patients is that stress related to housing can exacerbate these conditions significantly. The added stress makes diabetes and kidney disease a lot harder to manage. You did mention something that I wanted to ask you about. You mentioned services should be delivered in the home. And you said some reasons why, but I was wondering if you could tell us a little more about why you thought at-home services were more appropriate for this individual.
Well, she really does not have money to travel. Plus she has a job, which she doesn't want to lose, considering she's the only source of income in the family. So making her travel for these services would be a hardship for her.
Absolutely. It is an extra burden on top of what seems like a fairly burdensome life at the moment. Carol, could I ask from where you're joining us and what your job responsibilities are in your current role? Or
I am the Assistant Vice President of Health Programming for Lantern Community Services, which is a supportive housing and shelter agency. And I've been working in community health for about 35, 40 years.
Well, thank you for your service and for your insight. Is there anything else you'd like to add?
I don't think so. I might consider, I would want to know whether she has access for virtual participation, maybe in a diabetes self-management group,
Mm,
which could probably help her as well. But again, with the limitation of travel costs, I would probably try to find one that was virtual.
yeah, I agree. Thank you so much for your insight and your participation.
You're welcome.
Fide, if you could pick one more for us, please.
Yes, of course. Thank you, Carol. And we have a response by Bella Dorn. I'm gonna unmute your line.
Hey, can you hear me?
Yes. Hi, Bella. How are you?
I'm doing well. My responses are actually pretty similar to Carol's and what has already been said. Definitely the non-medical challenges impacting her chronic disease could range from, the physiological stress of having that anxiety and depression surrounding, the uncertainty and the instability in her finances and housing situation. Also, if you're worried about finances, maybe you're choosing maybe foods that are like less healthy, more affordable, but perhaps more processed, and that's further exacerbating your chronic conditions. And then as for types of services, I definitely think that, just having like a dedicated like housing caseworker or just somebody to um, for the patient to have a connection with, so that way they can help navigate the different housing options that might be available. Or something that I learned about when I was in my graduate program, which I thought was pretty cool, is like a legal medical partnership where this certain attorney will literally work with those under threat of eviction to work with them and their landlord to help kind of negotiate, like, okay, this is what's happening. How can we move forward without, needing to evict your tenant, and also ensuring that you as a landlord receive the money that you've contracted to get. I really liked Carol's idea of the services being delivered in the home. That's actually something I did not think of. My suggestion was to ideally have the services be something that's within the capacity of the FQHC or through like a community-based organization partnership. So kind of like, the organization that sounds like that Carol works for, having like a really direct connection with them in order to help facilitate these services for our patients.
I agree and appreciate your insight. Could you share with us the organization you're coming from and what your role is, please?
Yes, so I work for an FQHC, Outreach Community Health Centers in Milwaukee, Wisconsin. I am the population health specialist, and my role is kind of like a mixed bag of things. I do some care coordination, but then I also do work in like the quality department. So I'm receiving all like the satisfaction survey responses from our patients and helping them to kind of fulfill those care gaps that they might have for preventative care, such as like breast cancer, colorectal cancer screenings, cervical cancer screenings, also monitoring high blood pressure, controlling for that, and then also uncontrolled A1Cs for diabetic patients, just to name a few things.
Well, thank you for your service, and I'm very appreciative of your insight. If I may make a comment about something you mentioned legal partnerships. And legal partnerships, I've noticed, have been mentioned by FQHCs that I speak to sporadically. There are many resources that are available for FQHCs and for housing administrations. If you or anyone else in this call is interested in networking people to those services, we have relationship with the National Center for Medical Legal Partnership and would be happy to facilitate that. But thank you so much for your service and for your insight.
Thank you.
Thank you.
Could we transition to the next slide? Yeah, and just to go over it. So I will say that individuals in my field often do not have the training or the benefit of time to give this the social aspects of these patient care interactions the appropriate time. We rely on folks like our two speakers to facilitate that and allow that to happen. So thank you for your service. And let's look at some of the details here that have been mentioned and some that were not. So this is a 67-year-old individual that has two very serious chronic medical conditions that when they do get worse can create significant disability and significant burden in one's daily life. In taking a look at these, or in hypertension as well, the wellness examination is a great opportunity to catch up on these things and to perform an SDOH screener, because you can often catch things like this. Many organizations integrate these into their initial patient intake. When we look at the patient's vitals, we see that she's tachycardic. Her blood pressure is uncontrolled at the moment, a little high, and she's breathing very quickly. That points to physiological stress and maybe poor control of her conditions. What makes me feel even more confident about that is I only have one other set of vitals to look at, but looks like she was doing pretty good 6 months ago. So when I look at this as a physician, I say, what changed? In this clinic, I would have the benefit of an SDOH screener that would help me to determine that. The diaphoretic and nervousness as well helps me think that this is an individual that's going through significant psychosocial stress who needs support. Next slide, please. I use the Well-RX screener, which is a screener that was designed for a particular FQHC, which we'll review in a case study in a moment. But we're seeing a couple things here. The patient is concerned about homelessness. She's had past trauma related to eviction, and that past trauma can be debilitating. And it seems that her stress may be related to that. She has trouble paying her utilities and for finding a ride. This is an individual that that has significant barriers to meeting care. And as our speakers both mentioned, this is an individual who would benefit from services in the home, virtually, or via phone. Next slide, please. You'll notice that she mentions that. Oh, I'm sorry. There's nothing pertinent in this slide. Next, please. And then looking at the sodium, the picture here points to someone who is having challenges in controlling her chronic disease states. And in addition to the medical supports that her nurse practitioner will give, social supports are just as important in controlling and supporting that. Next, please. And to look at the details. She's the only source of income. Savings are gone. She's overwhelmed. This is someone who is a good candidate for social services intervention. She's diagnosed with GAD and MDD during the visit, but the diagnosis and the medical treatment is just the first step of controlling that. She will be networked to social services, and in a person-centered healthcare administration model, would work with the community health worker or associated professional to work on those and coach on those. Next, please. Now to look at some of the evidence of health and housing. Access to safe, affordable housing supports people's physical and mental health. Research has shown this repeatedly and consistently. And if you'd like more data regarding this, this is a resource that I think may be appropriate. The link on the bottom left when you get the slides. Next, please. Housing access and quality has a large impact on the development of chronic disease states. Shasti et al. Quantified the prevalence of housing and food insecurity in the chronically ill. What this paper found is that 36.71% of the chronically ill experience housing insecurity. The presence of cardiovascular or lung disease increases the likelihood of experiencing housing insecurity by 69%. And the presence of cardiovascular or lung disease increases the likelihood of experiencing, I'm sorry, that was meant to be food insecurity by 75%. Chronic diseases have a very intimate connection to our health, and housing has a very intimate connection to chronic diseases. Next, please. Health and housing, the evidence. A link to this resource will help break down in detail the different ways that housing specifically and particularly affects chronic disease and the individuals we serve in our communities. Some of the takeaways are that access to safe, affordable housing is a major contributor to the SDOH. Poor access to these resources has an outsized impact on individuals experiencing chronic disease states, and supporting access to housing has a strong measurable impact on health outcomes. Now, these might be obvious outcomes or obvious statements for those of you who work in this field, but at times when making proposals for changes within your organization or proposing programs, being able to cite key resources can help to support your argument and support your work. This resource you may find appropriate in doing that. But looking more in detail about stability, people who are not chronically homeless but face housing instability are more likely to experiencing poor health in comparison to the stably housed peers. Residential instability is associated with health problems among youth, increased risk of teen pregnancy, early drug use, and depression. A review of 25 studies that examined the impact of foreclosure on mental health and health behaviors found that all of the studies reported that foreclosure was associated with worsened outcomes, including depression, anxiety, increased alcohol use, psychological distress, and suicide. Safety. A number of environmental factors within homes are correlated with poor health. For those of you who are in communities that have old housing stock, particularly those made before the 1970s, have populations that are at increased risk of lead poisoning, which intimately affects the neurological development of children and causes, at levels of toxicity, impacts that significantly. The affordability question, a great deal of Americans struggle with housing affordability, and HUD programs and HUD vouchers only meet about half of that need. And neighborhood. Researchers have found that the availability of resources such as public transportation, the one's job, grocery stores with nutritious foods, safe places to exercise are all correlated with improved health outcomes. Living in close proximity to high volume roads, in contrast, is a danger to health and can result in increased rates of respiratory diseases such as asthma and bronchitis. Studies have found that when walking past a vacant lot that had been greened with trees and grass, that individuals experienced a significantly decreased heart rate just when walking past that. Now, if you can consider how that would impact an individual if they're around quite a few green spaces, and you conceptualize that individuals that experience tachycardia who have chronic disease are at risk of bad outcomes, such as stroke, heart attack, and so forth, having a green space in a heavily populated area has a very real impact on the number of the individuals that experience medical emergencies related to cardiovascular disease. And that's just one example. Next, please. Many of you come from organizations that integrate a person-centered healthcare model at your when caring for your community and caring for your patients. For those of you who do not, or for organizations that are considering buttressing their person-centered services, this link to the IDA Institute will give you some more details on how to conceptualize that and some steps you can take to increase the person-centered care at your institution. Next, please. Now let's discuss some delivery models for housing resources. This model for an outpatient framework is appropriate for other SDOH concerns as well, such as food insecurity and employment assistance. Networking individuals to resources is complex. A strong SDOH screening policy and policies that allow this data to be shared and used appropriately can increase the efficiency of service delivery substantially. And this results in increased or improved patient outcomes, but also improved outcomes in the workforce. SDOH fatigue and SDOH burnout is a major contributor to burnout in the social services professions and the clinical professions as well. Having a system that collects, manages, and uses this data appropriately, or improving the collection and use of this data can help you to retain your staff and to keep your staff happier. Next slide, please. Now, looking at this generic outpatient framework, the model is designed to reflect the patient care continuum in a PCP clinic. The model is broken down into 3 steps: the intake, where the patient sees the nurse or the nurse assistant who performs screeners and performs vitals, the clinic interaction with the doctor or the nurse practitioner or advanced provider, and then follow-up engagement. In intake, administrative tasks are performed, patient vitals and labs are performed when appropriate. The SDOH screener is also performed along other screeners. The SDOH screener, it can either be done on paper or put directly into the EHR. Depending on your healthcare system and the system in which your healthcare performs in, you might find either or more appropriate or more convenient. In the consultation, the clinician sees the patient and reviews the SDOH screener along with other patient information. Now, the SDOH screener is appropriate and effective in this context because it saves a great deal of time during the clinic interaction. If a physician or a nurse practitioner is sitting with a patient and has access to the screener, they can decrease the amount of time or increase the efficiency of talking about the social concerns of the patient significantly and focus more on the medical complaints and referring the patient directly to social services when appropriate. The clinician in this context can then approve a referral to social services, either in-house or at the patient's home. Depending on the physical makeup of your facility and the availability of staff, this can be performed in clinic. However, the best results are obtained when this is performed in a community setting or in the patient's home. There is voluminous literature that describes this relationship. In general, social services tend to be more effective when they're performed in a place where the patient is comfortable. That can be in clinic, but that's often better served in a community setting, such as a community center. Oftentimes, organizations have relationships with local faith or community organizations and choose to do it there. And in some cases, the home visit may be more appropriate as well. When you have access to information in SDOH screener and you're able to meet someone in their home, you can see these things in detail. And also, you can see the person in a place where they are more comfortable. Asking someone about their housing access and about issues with their housing access, these are very intimate and very uncomfortable topics for people to talk about. Putting the patient or putting the person in the most comfortable environment that they would like is a good way to make sure you get the best available data and that your patient and your person are more likely to succeed in overcoming those challenges. Next, please. And an outpatient framework. Many FQHCs work in concert with their local community hospitals. This can cause challenges with SDOH screeners and with collecting data on housing access because community hospitals often have their own individual screening policies and so forth. FQHCs in partnership with community hospitals can serve key roles in advising in the performance of SDOH screeners and in performing social services. These assets are something that FQHCs can bring to the table when forming partnerships with community hospitals and supporting community hospitals in their care. Next, please. If we consider an individual that was admitted for CKD or hypertensive emergency that looks like Mrs. Torres, when she's admitted, she'd receive an SDOH screener during her intake. The physician would make referrals and integrate results in the care during the inpatient stay. And when the patient is prepared for discharge, they would be navigated to resources. In particular, the best evidence supports coaching and continuum planning with a community health worker or associated profession to work with the individual on those challenges after their discharge from the hospital. These interventions have been shown to decrease emergency room visits and decrease number of days in the hospital during subsequent stays and decrease the number of subsequent stays as well. This is a great way of supporting the patient and supporting the burden of the healthcare system as well. Next, please. Here's a list of actions that can be taken by community-based organizations to support health housing partnerships in their communities. These are both supported by the literature and based on my own analysis of consultations with FQHCs across the country. HUD voucher recipients are, supporting HUD, to go down the list, supporting HUD voucher recipients to strengthening partnerships with local property owners is a practice that many FQHCs, particularly those in rural communities, have mentioned as being particularly effective in both supporting their network and supporting their persons as well. HUD voucher recipients are required to secure their own rental housing. In this program, the voucher pays a portion of the rent to the landowner is paid directly through the program. This can improve stability and decrease risk for landowners, but often landowners don't have a great understanding of the program and benefits that it can have for them financially. Many health centers and person-centered care consortiums had supported housing access by developing their communication network with local property owners. Educating property owners about HUD voucher programs and offering direct referrals can help support landowners' bottom line while allowing quick transition of voucher recipients to safe, appropriate housing. For those of you who live in communities that have housing that is likely to have lead or is at high risk of having lead toxicity, the FQHC or Housing Administration can also help to link landowners to services regarding the removal of that lead and so forth. Two, form partnerships with local Ross SC grant recipients. The Ross SC grant funds housing navigation staff. Forming and strengthening relationships with Ross SC grant recipients in your community can help increase the navigation to resources and increase the ease and burden on your own organization while supporting your partner organization's efforts as well. We'll go over some details about that in a moment. 3, strengthening relationships with your local housing administration. Regular communication and respectful communication between FQHCs and housing administrations always leads to good results. And for those of you who have been able to create those relationships, good for you. And for those of you who are looking to strengthen those, my recommendation is to increase communication as much as you can, and to examine the individual needs of your organization and your local housing administration. You may find there are areas where you can critically support each other in key places that support patient outcomes and support your organizations at the same time. Supporting staff knowledge of the SDOH and their implications on your population. When I went to medical school, the SDOH wasn't a thing yet. The SDOH has been pushed greatly in the last 5 or 10 years, and as a result, it's new information for many of us. Increasing the understanding of your staff of the SDOH and it as a framework, an epidemiological framework, can help to assuage their frustration when working in difficult situations, can give them tools to understand and intervene, and can create a culture of diversity and understanding at your organization that helps everyone. Increasing your understanding of community housing stock and limitations. What does your community housing stock look like? Were the majority of buildings built in the 1970s? If so, you may have an issue, a lead issue that may need to be addressed and managed. In many states, legacy housing often have outdated heating and cooling infrastructure, which can increase the likelihood of house fires. When I worked in Jonestown, Mississippi, in south of Memphis, we had 3 house fires in a community of about 3,000 from an old design of heater, which was likely to start fires. These had not been replaced because the individuals did not have the means to replace that. Having a strong community health worker force that performs in-house visits at times can help to increase your organization's understanding of that environment and help you to support individuals and intervene when there are risks that put their health and safety at serious jeopardy. And finally, supporting the expansion and development of CHW and related staff. Next, please. Partnership opportunities, the Ross SC grant recipients, as mentioned previously. For those of you who are interested in looking, you may find that there are Ross SC grant recipients in your metropolitan area or in your community that are potential partnership opportunities. If you go to this slide when you receive the slides, you'll find a link to the details on the Ross SC grant, which will be coming up this year and will be open to applications, and the resource download of all the 2019 recipients of this grant. You can use that list to locate those grant recipients and offer partnerships with your own organization. Next, please. States can take a variety of approaches to authorize payment or encourage CHWs. In the past, there were challenges to expanding and supporting CHW workforce because of the cost associated. That cost has been assuaged in certain states by the expansion of state Medicaid and insurance networks to cover CHWs in certain circumstances. The complexity is every state is different and has found different ways to support different services. For those of you who come from any of these blue states, the laws and changes in the law to support and finance CHWs in health centers and associated organizations, many of them are very recent. And taking a look at those details and seeing if those that you may have opportunities for expanding your CHW resources may be appropriate. On this slide, you can take a link to the Kaiser Foundation report that details all of the different states that cover CHW services in any capacity and what exactly they cover and how to get those resources. Next, please. And similar for this as well. Next, please. And on CHW planning, In speaking to people here in DC and to FQHCs around the country, I've been very happy and surprised to hear that a number of states have integrated new CHW coverage policies this calendar year. The most recent is Michigan, which I just heard about this week. I don't know if we have any individuals from Michigan here, but in this calendar year, CHW services will be covered in part through Medicaid expansion. This is a copy of the law and the details of the law. And if you go to this resource, you'll find details on how exactly this will be done in Michigan and how exactly it will be funded. For those of you in Michigan, my recommendation is to take a look and to see if there is an opportunity to expand your CHW services at your organization. Next, please. Health and housing are best supported through provision of person-centered healthcare models that address the SDOH. Developing and strengthening person-centered healthcare networks, and those include health and housing partnerships, requires an understanding of the SDOH environment in your community. The SDOH environment is different in every community. This can't be performed comprehensively with staff knowledge alone. Recommendations are that a combination of staff knowledge and research and data collection in your community will allow you to alter existing SDOH screeners to make sure you're asking the right questions. Just adding 1 or 2 extra questions to established screeners can help give you key data that can help you to navigate people to resources more quickly and more efficiently. You may notice that tailoring SDOH screeners to your community needs allows you to network people more appropriately and to more appropriately use or more efficiently use your CHW staff. And if you follow a link here, you'll see a publication that gives 6 examples of organizations that did this. But to talk briefly about the WellRx pilot, this was a primary care clinic in a larger healthcare system that was looking to increase SDOH supports in their community. To do this, they got a grant to create a new SDOH screener for their community. In doing that, they created the screener, collected data, and were able to more effectively link individuals in their network to services through their CHW staff. Next, please. Now, at this primary clinic, care clinic, they started with paper SDOH screeners in intake, similar to the model I showed you previously. Before starting the program, they collected data on 3,000 individuals in their community. They did this to assess what are the most common SDOH concerns and are their program offers reflecting that. And you can see to the left the results. We can see utilities, income, and employment in this particular community were the most serious concerns. But if we were to take a random assortment of communities similar to this all over the country, you would see these different bars switching places and being larger in certain cases and smaller in others. Collecting that data on your community is an important way of making sure that the resources reflect the need and can help to lead you to more efficiently use staff and more efficiently use resources. On the right, we have the process that this organization used in creating its program. They started with an institutional interest in SDOH policies and the social determinants of health. They received a grant to develop an SDOH screening tool. But data has shown us that for organizations that prioritize the social determinants of health, screening for the social determinants of health, and the subsequent intervention, they experience measurable increases in the satisfaction of all their clinical professionals. What you may find is that increasing your social supports in your system allows you to retain employees more readily and for recruit them more readily as well. Next, please. And this is the WellRx questionnaire that we used for our case study. And let's talk a little bit about the details. Many people use the Prepare screener, but the Prepare screener, the WellRx screener, and other SDOH screeners are general. They're designed for a general community across the country. Research has established that FQHCs, small clinics, and other organizations should adapt SDOH screeners to meet the individual needs in their community. You have the bandwidth to do that, and research has supported organizations in doing that. My recommendation, if you use an SDOH screener, is to take a quick look. Are there some areas where it could be improved? There may be. And if so, there may be space to do the necessary research in order to make that better. Next slide, please. And the one after that. Now, let's take a minute to do a quick discussion question as we finish. Your health center is considering altering an existing SDOH screener to improve information regarding housing access in your community. This effort is in context of an ongoing partnership between an FQHC and Housing Administration. Which questions would you add to the screener to better assess access in your community? Specific and particular questions. Now, we'll take a few minutes to consider this, and while we're doing that, Fide, could you go through the first and second pages of the screener? I'll ask all of you to take a look at the screener, take a look at the housing questions. Would you ask something different in your community? And if so, why? I'm looking forward to hearing your opinions and your insight about that. We'll take 2 minutes. And please make use of the chat or raise your hand. Any more seconds? Okay.
Okay, so we do have some responses from Carol. Carol, would you like to add more onto that?
And if I may add a prompt, Carol, I saw you mentioned a number of things, and for those related to housing and living, what about your community would make you want to ask those?
Okay, as I said, for me, we serve people with mental health challenges, people living with HIV and other chronic diseases, as well as young adults coming out of foster care, all with histories of homelessness. Our population is aging, so mobility questions would come up for me. And safety in terms of handrails if needed, things like that. Daily living tasks, can they complete them? Can they cook? Are they able to cook? Are they able to bathe? Do they need assistance with it? What's their educational level? Are they receiving benefits? If so, how is that working? Is that enough? You ask about if anyone in the house is using drugs or alcohol. but you don't ask specifically, do you have a history or are you currently using any substance, including alcohol, and maybe smoking, and then pending legal issues, whether it's CPS, whether it's probation they're on, those kinds of questions can determine their availability for work, for example. If so, what kind of work are they able to do? So those are the kinds of questions I think I would look at in addition to what's asked.
And thank you for your opinion and your insight about that. I have to agree with the legal issues almost everywhere. Putting that on an SDOH screener is almost always a good idea. But from what you mentioned about your community and the specific barriers that people have, and you've mentioned the length of time that you've worked in that capacity in your community. The knowledge of having a long time working in a community and interacting with people can be very important in informing what questions are asked and how they're asked. But in particular, adapting that, if you use a generic screener in this circumstance, you would miss that information. And that's information that you've identified based on your professional knowledge that are very important to members of your community. So when looking at that data, you mentioned very clearly how it affects individual care. If you were at a system that collected this, or you may or may not be, but if this information was collected over a long term, you'd be able to see key patterns in the barriers that your population is experiencing and may be able to think of or design new interventions as well. So thank you very much for your insight regarding that.
Thank you.
Now we are at the end, and so we will we'll go. Oh, we have an individual that seems not to have audio. Would you please read their response, please, Peter?
Yes, of course. Her name is Heather Garrett, and she is the behavioral health manager at Shingletown Medical Center in Northern California. And she would like to ask if the client has access to heat or cooling for their home. I have found that many of our clients do not have heat, insulation, or cooling in their homes. They do not take it to housing authorities because there are no other housing options for them to move.
Yeah, so that's an excellent example. Thank you so much, Heather, for doing that, for saying that. And it's another example of when you have professionals that know their communities well. Adding information on the screener based on that can be an important step of trying to link people to those resources. It also makes it standardized as well. At times, CHWs, LPNs, or other individuals who do these assessments will ask these questions, even if they are not on a screener or established protocol to ask these questions. What you may find if you're an administrator or someone who manages individuals in these professions is that standardizing it, putting it on a screener, can ensure that that data is collected and that there are follow-ups about that. Thank you, Heather, for your comment, and thank you for your service to your community. I think we have a hand. Carol, did you want to add something else?
Actually, in thinking about at least public housing in New York City, asking questions about personal drug or alcohol use and noting it or documenting it could be problematic because people can lose their housing if substance use is going on in their home.
That's a very good point. And I think it speaks to the importance of a process. When forming and expanding an SDOH screener, ideally it should be an interdisciplinary conversation between professionals and should include a reflection on what the unique legal environment is in which your individuals are working. Because if there isn't an issue like this, the data could compromise your patients, and you also might find that the patients just don't answer the question. So creating and carefully crafting an SDOH screener is very important in collecting that data. Thank you for your insight on that, Carol. And looks like we are right at 2 p.m. So I'll just briefly talk about some of the other resources that I have available for you. Could you go up one? Oh, you're good. You're good. Sorry. It's the previous, please. Excuse me. Here is a detail of a framework I designed based on an analysis of about 12 case studies of how to increase the SDOH culture at your organization. There's a text in the slide that details that as well. Next, please. For those of you looking to change an SDOH screener, there's often institutional resistance to changing established screeners because they're established screeners. This research paper details the recommendations about altering SDOH screeners, noting that individual organizations have the capacity and should alter those screeners when they seem appropriate. The literature also goes through a process to do that. You may find, if you're interested to do that at your organization, that giving your supervisors and colleagues access to this publication can be an important foundation to starting the conversation and starting the process. Next, please. And unfortunately, we do not have time for Q&A, but Fide, I'll let you take it and you can go to our contact information. I'm Dr. Kevin Lombardi, and I'd be very happy to hear from any of you if you would like consultation or more information regarding the things I have covered. And thank you all for your service to your communities and for your time today. Fide?
Yep. Thank you, everybody. And this is our contact information, just as Kevin just mentioned. And just a kind reminder to everybody before leaving that we have 2 upcoming webinars this week, one tomorrow at 1 p.m. on net screening and housing partnerships, and another one on Wednesday, June 28th at 1 p.m. as well, Eastern Daytime, on community health worker workforce development. The registration links will be provided to you in the slides that I'm going to send to you via email after today's session. And also another reminder to please complete our post-evaluation survey. Thank you, everybody.
Thank you. And thank you for your service.